So, Dr. Bodve, I mean, it's really interesting to see both the randomized clinical trial data and the real-world data. What's your experience with oral SERDs, in particular elacestrant, in your clinical practice? Are your results kind of similar to what we've seen so far?
Yeah, I think the real world data was very reassuring. I think that subgroup analysis showing that patients who were on CDK4/6 inhibitors for at least 12 months is definitely the patient population that I'm utilizing elacestrant in practice. I would say my results in the real world in practice with elacestrant vary a little bit. And I think it's because there are probably so many other factors in the biology of every patient that leads to some of this variability in progression-free survival in the real world. I would say that most patients do see at least 6 months of benefit, some a little bit longer. I haven't, had too many patients where we've reached upwards of 10 or 11 months, as we saw in these very endocrine sensitive population of patients in the subgroup analyses. I do think that with some of my real world experience, I am reserving a lot of the monotherapy oral SERDs for patients that really truly have endocrine sensitive, mostly bone only, kind of indolent disease, where we see a lot of the efficacy with monotherapy endocrine therapies. I think where there is probably more promise in my mind is with the combination strategies. And we've seen some data for several of the combinations with both elacestrant and imlunestrant that look very promising. I'm really looking forward to integrating more of the combination approaches into clinical practice.
Yeah, I mean, it's really interesting. We have such a plethora of choices now in the second line. It's going to get even more complicated in the not so distant future as more mTOR PI3 kinase drugs come online and more oral SERDs come online, more oral SERD strategies, potentially changing it ESR1 mutation as opposed to waiting for clinical progression may or may not make it into clinical practice. But I think that we have so many things here, it's going to be hard to know how to use them. And I agree with you. I think I tend to reserve this for people who've been on their endocrine therapy for a long time, have minimal disease, but maybe they've developed an ESR1 mutation, maybe they have one or two bone mets that are worse. You radiate them, you feel like you want to switch. Sometimes we don't, but sometimes we do. Those are kind of the people, the patients I do it in. It's really interesting though. I've had some people who've been on their endocrine therapy for 5, 6, 7 years with CDK4 who I would love to use this on. And sometimes it works and sometimes it doesn't. It's really interesting. And I think it has a lot to do with our understanding of what's driving resistance. Is it amplification of the PI3 kinase mTOR pathway? Is it simply ESR1 mutation? Is it something else like FGF or P53? We just don't, the problem is we don't have anything for P53 and FGF right now, but we do have things, PI3 kinase drugs, and we do have and mTOR drugs, and we do have ESR1 drugs. So it's really interesting. I mean, it's really interesting to see. I am also, like you, very kind of satisfied to see this because I didn't believe that this was going to work as well in the real world because I agree with you. My initial experience with it, like all of us, was in these the patient's been through sixth, seventh, eighth line therapy, and suddenly elacestrant comes on, it becomes approved by the FDA, and we're like, we have nothing else to give people, so we started giving it to them. And we would see 1 or 2 months or 5 months or 3 months of PFS. But now in the patients who are a little bit more endocrine sensitive, I think that we do have an opportunity. The question is, do we use this as monotherapy? That's going to be the big question.
Right.
Kind of moving away from monotherapy to really more targeted combinations in the second and third line. And it's going to be interesting to see where this goes. I agree with you. I mean, when there's really interesting data, combining oral SERDs with various targeted agents, they seem to be safe. In some cases, they seem to be efficacious. And it's going to be a really interesting time.
Right. I think you're right too. Options is what you highlighted. And we have a number of options in the second line and third line setting in terms of endocrine based options and potentially combination strategies. I think it's going to come down to disease factors, kind of pace of disease, sites of disease. I think it's going to come down to differences in the toxicities between our endocrine therapies, even between the oral SERDs, we can see clear differences in toxicities. So part of it will be a discussion with the patient on not only the clinical outcomes with each of these oral SERDs or PROTACs, but also the differences in terms of the toxicities. And, between the two oral SERDs, we see a little bit more fatigue and nausea with elacestrant in my experience. We see some fatigue, but also some potentially diarrhea and transaminase elevations with imlunestrant. And then I haven't had the chance yet to use vepdegestrant, but in general, that seemed to be a fairly tolerable drug, although, again, somewhat limited progression-free survival advantage as monotherapy in this ESR1 mutated population.
Yeah, and that's the problem of vepdeg. It was compared to fulvestrant only, and I think that that's the problem with randomized clinical trials. When it was started, it was a great idea, single agent fulvestrant. Now it isn't. And I think that it's going to be really interesting to see vepdeg was approved by the FDA, as you know, and it's going to be really interesting to see where we use it. I think that it may be used. Hopefully, there are combos floating around somewhere in phase 2 that may inform us a little bit, but we'll see. We'll have to see what happens.